Good evening. Welcome to the Leslie Smith Culture Center, to our fifth, I believe it says our fifth events, fifth series in our Medical Society workshop or panel discussion. Tonight we are going to talk about urinary incontinence. We got all the ladies, one gentleman back there, and myself, two back there, so we'll see what's happening. All right. Dr. Vance is going to come down, is going to introduce our speakers tonight, and we hope we get something out of it and enjoy the panel discussion. Thank you.
Good afternoon, everyone. Just to introduce myself, my name is Cornelius Mance. I'm a clinical urologist. I trained at University of Tennessee Health Sciences. I finished in 1973. It's been so long ago, I was like, how long? Then I did an internal medicine residency at Airline. I finished that in 1977. Then I came back to Memphis, did urology residency in 1980, and I came back to Chattanooga in November 1983. So that tells you that I've been around a few years. Okay? I'm board certified in internal medicine, also board certified in neurology and psychiatry. Even though I practice neurology, you get board certified in neurology, you 1/3 psychiatry, 2/3 neurology. And also I'm board certified in pain management, which basically I'm kind of like a pain management doctor that do not like pain medicine, because we found out that many times these medications, they do not change the outcome of the disease or the symptoms. Many times for us is that we have to realize that we have to do natural things or things that make sense, that promote the body to heal, to get better. Tonight we'll be talking about incontinence, and we're so fortunate to have a young man that is sharing the stage with me that is a urologist that deals with incontinence, in which, as you'll see with my slides, that this is a big problem throughout the world. And what happened to us is that as we understand this disease or this disorder, there are many things that we can do. But one of the things that everything has to be in the foundation is good nutrition, proper hydration, avoiding toxins and poisons, and taking care of yourself, exercising, and also have great relationships. I'll be talking about the urologic overview of urinary incontinence. What is urinary incontinence? It's the loss of bladder control, being unable to control urination. As you can see, it can be a minor problem or it can be a problem that greatly affects your life. Incontinence, if you think about 25 million people in America affected by incontinence. That's a big number, 25 million. 1 out of 3 people between the age of 30 and 70 experience loss of bladder control. 30% of women above 45 have stress incontinence, and 50% of women above 65 have stress incontinence. This is a slide that kind of shows you what I'll be talking about is the neurological aspect of incontinence. You can see that it starts in the brain, the top of the head, down through the brainstem, head down to the thalamus, to the brainstem, the pons, the spinal cord, and the lower part of the spinal cord. Many people don't realize is that the micturition center in the frontal lobe controls your ability to urinate, but also the same place, if you have ether there, it often affects your ability to walk. It can be associated with brain lesions such as stroke, multiple sclerosis, brain injury, Parkinson's disease, cerebral palsy, Alzheimer's. But then as you move down to the thalamus, where people can have strokes, which is the major relay for all of our impulses from top to bottom, that can cause you to have incontinence. But you have a pontine micturition center, which is located right here. That many times can be affected by strokes or the neurodegenerative diseases. Then you add this affect the spinal cord from trauma, or spinal bifida, or in multiple sclerosis. Many people have athletes who get injured, have acute spinal cord injury, become paralyzed, they lose the ability to control their urine. As you move down the cord, with MS and infected, but also you have the sacral micturition center in the lower part of the spinal cord. If that is injured by peripheral nerves, then you have peripheral nerves and diabetes. But many people have a condition called corticosteal syndrome, which you have acute injury to the lower part of the cord from ruptured discs and tumors, etc. But then you have another problem with respect to the nerves, damaged by diabetes, which is the most common, and also you have injury to the bladder muscles. And then you have the feature that controls this, also affected and controlled by the nerves. Types of incontinence, you have stress incontinence. That is when you have leaking urine, when you have increased pressure such as coughing, sneezing, laughing, exercise, and lifting heavy objects. That's very common with women. You have urgent incontinence, you have sudden intense urge. And what happens is that you have involuntary loss of the urine. You have overflow incontinence, which you have constant dribbling of urine because the bladder doesn't completely empty. And many times for this, we talk about a spastic bladder versus a bladder that's hypertonic, that doesn't completely empty. Then you have functional incontinence. If you have any type of impairment, physically or mentally, you have to go to the bathroom and you can't go, what happened? And this is common in the hospitals where people there, they control their urine, but because they push the light and the person don't show up for 30 minutes or 45 minutes, they cannot get to the bathroom, so they have incontinence. Then you have mixture, which has a combination of stress incontinence and urgent incontinence. But the major one we talk about is stress incontinence and urgent incontinence. There are temporary incontinence that take place, many times related to foods and drinks. And you think about alcohol, caffeine, carbonated sodas, artificial sweeteners, chocolate, chili peppers, fruits high in spices and sugar and acid, especially citrus fruit, blood pressure medication, heart medication, sedatives, muscle laxatives, can cause you to have temporary incontinence. Incontinence may be caused in which you have very good treatment. If you can correct the treatment, what happens is it goes away. And this many times is associated with bladder infections. When we have people with multiple sclerosis and they come in with problems, one of the first things we think about is check their urine to make sure they do not have a low-grade infection. Many people have infections facing silent, but just want to have incontinence or have problems with respective organ. Then you have constipation. In the United States today, constipation is rampant because most people do not have 1 or 2 bowel movements a day. There are many people that state they have 1 bowel movement a week, which is not good. There are persistence incontinence associated with pregnancy, in which you have hormonal changes. And these hormonal changes and fetal weight cause stress incontinence. That's very common. Childbirth, vaginal delivery, weaken the muscles. That's why it's very important to have a very good obstetrician. Because if you have a very good obstetrician, what happens is that they basically take very good care of the woman as they deliver the baby. Change in age. As you age, your bladder becomes weaker and protrudes, and many times will leak. Menopause. Women have decreased amount of estrogen production, therefore they begin to have what? The lining of the bladder and the urethra become less healthy. Enlarged prostate cancer associated with it, obstructions of any tumors in the bladder can cause problems. And as I talked about, neurological disorders such as multiple sclerosis, heart disease, stroke, brain tumors, spinal cord injury, but you cannot leave out Alzheimer's or dementia, because that is extremely common. Risk factors. Gender. A woman is more likely to have stress incontinence than a man. As you get older, the muscles in your bladder become weaker. Being overweight, extra weight produces increased pressure in the abdomen, therefore causing increased probability of leaking, especially with coughing. Smoking. That's one of the things that, if you think about smoking, exacerbates almost every condition. So that's why smoking should be taken off of the table. Your family history. If you have a close family member with urinary incontinence, especially urgent incontinence, your risk to develop the condition is very high. And many diseases such as diabetes, which is basically rampant because there's so many people who have insulin resistance, and with time will develop diabetes. And also, at the time of diagnosis of diabetes, 10% of the people have peripheral neuropathies, which is one of the things that I showed in the slide can affect the nerve that goes to the bladder. 50% of people will develop peripheral neuropathy with diabetes. If you have good control, you delay this development. When do you need to see a healthcare provider? One of the things that we have to realize that knowing all these facts, we must know what we need to do in order to get properly evaluated and treated. If you have needed to urinate more frequently and suddenly this happens, there's a change. You need to see a provider. If you have clotted urine, if you have blood in your urine, if you have pain on urinating 8 or more times in one day. Many people we have patients that comes in who has been having polydipsia, polyphagia, polyuria, and they don't know why they have it. The high risk of this says you got diabetes. And they find out many of these patients have blood sugars of 6,700 or coming out in the hospital with ketoacidosis, which is a high injury, cause high mortality. Passing small amount of urine after strong urge to urinate. Trouble starting or having a weak stream while urinating. And Dr. Okafor will talk more about this because this is what he deals with. When you start treating people with this here, the general rule is use the simplest treatment as possible. Pelvic exercises. We always talk about Kegel exercises. Contracting the bladder and the floor of the pelvic, which basically improves the strength of the muscles, therefore increase your ability to control your urine. Urgent suppression. Help control strong urges to urinate so you can make it to the toilet. Examples. Try distracting yourself to keep your mind off needing to urinate. Take long, relaxing breaths. Hold still, squeeze the pelvic floor muscles. And you have seen this, the kids always know how to do this. And you see this happen all the time. But us as adults, we forget this. Time border. One of the things we find that most people who have trouble with incontinence, they have to begin the time border. That means that every 2 hours go to the bathroom. But many patients will, you talk to them about problems, and they will say, I don't have to go to the bathroom, and 10 minutes later, I gotta go. And so what happened to us, time border helps. There are medications that we can use, estrogen creams use, bulk agents, medical devices, biofeedback, electrical nerve stimulators. And one of the things I would say about electrical nerve stimulators, if you ever have one of those placed, make sure they are MRI compatible. Up until the last several years, many of these stimulators that you put in your body was not MRI compatible. And what happened to us is that if you have these conditions, more likely you will need an MRI sometime in the future, because this is the Rolls Royce of treatment. It's the best treatment. It's the gold standard for treatment. So you need to be able to get the best test. 20, 30 years ago, the CT scan was the Rolls Royce, but the MRI has replaced it. It shows you pathology and structures that look like textbooks that we saw 30, 40 years ago. This is an overview of urinary incontinence from a neurologic standpoint. Remember that this condition can start at the top of your head, go down to the brainstem, go to your neck, and also the spinal cord and the lower sacrum, and then also the nerves and also the muscles controlling this. And so at this time, we have the opportunity of having Dr. Okafor, who will come forward and will talk to you about the medical side, the surgical side of treating this disorder, in which the people that I was told them first about incontinence, they were excited because this can resolve many of the problems that we take for granted, but we have opportunity to have treatments that can be of great benefit. I'd like to present to you Dr. Okafor from Urologic Hospital.
Thank you, Dr. Vance, for that introduction. I'm Dr. Henry Okafor. I'm a urologist at Erlanger. So my background, I did medicine at Howard University in DC, and from there I went to upstate New York to do a urology residency, and then Cleveland, Ohio for my specialty training. Originally called female pelvic medicine and reconstructive surgery, but we recently changed our subspecialty to urogynecology or urologic pelvic medicine and surgery. So I'm subspecialized, which means most of my patients are women who have pelvic floor disorders or urinary incontinence and things of that nature. So that's where 70% of my patients are. I was asked to give a talk today about incontinence and pelvic floor disorders. So it's a broad topic. There's a lot of things I'm trying to cram into 15 minutes here, so forgive me if I appear rushed or quick. So we'll get started here. Dr. Mans was kind enough to do half my job for me by defining incontinence for all of you, so I'm not going to waste too much time here. So it's an involuntary loss of urine. I'd like to pay special attention to stress incontinence, which is the most common, like he said, and urgency incontinence as well. So a lot of my patients, I try to tell them when they complain about urinary incontinence, do you think it's because you cough or sneeze and you lose your urine, or is it that you just can't make it to the bathroom on time? And honestly, 60% are confused. They don't know which one, just know they leak and they're fed up of it. And so I try to tell them to kind of pay more attention to it, pay close attention. When do you leak? What makes you leak? And that gives me a better idea of how I can proceed with treatment options. But in fairness, a great majority of women do have mixed incontinence, so they have both, and there's just no way to quantify which one is worse, and you can't fault them for that. Epidemiology, so it's very common. So it's 19% of the female population in the US and 10% of the male population above 60 years old have incontinence. In males, it's in the peculiar population that have had prostate surgery. They're the most common population that will have incontinence, but they do also have overactive bladder, which is a medical condition that leads to urgency incontinence. And just to give you an idea, this is an expensive problem. If you're not spending money on pads, you're spending money on medications, or you're spending money paying your copay for surgery. So over 600,000 surgeries have been performed for pelvic floor disorders, including incontinence and prolapse, and it costs about $26 billion dollars in Medicare dollars. So we've already talked a little bit about non-surgical treatments. So we can change some modifiable risk factors. Weight loss can be very helpful in stress incontinence. Like Dr. Mann said, increased pressure on the bladder will lead to increased incontinence. Bladder training, so if you have an issue where you can't make it to the bathroom and you know that every 2 hours you're going to the bathroom, try going every 1 hour. Maybe try to meet that urgency before it hits, because by then it's too late, right? Eliminating the irritants. Caffeine is a big one. And maybe when I moved here 6 years ago, it was the first time I heard a patient say they don't like water. They only drink sweet tea or soda, which I found unbelievable. But that can be a big risk factor. So eliminate the caffeine, the soda, the sweet drinks, and just stick to water, and that would be helpful. And smoking cessation as well. If you smoke, you're going to have chronic cough. If you're going to have a chronic cough, you're going to bleed when you cough, and that's going to make things worse, right? If there are other things you can do, pelvic floor exercises. The Kegels are something you can do on your own. The squeeze the pelvic muscles to strengthen the bladder. But if you're not able to, or if you don't feel like you're doing a good job, you can ask your primary care or your urologist to get a referral to a pelvic floor physical therapist. There are so many in the Chattanooga area. I was impressed with how many we have here. There's Benchmark, there's Results Physiotherapy. Earlier, we have our own physiotherapist. And these are some specially trained doctors of physical therapy who can help teach you how to do these exercises properly if you're not confident, if you're doing them well, and then use a machine called biofeedback to help you do a better job. There have been several studies that have looked at physical therapy, and they've shown remarkable improvement in incontinence, in the sensation of vaginal prolapse, and some patients have not required surgery anymore because they've done so well with physical therapy, believe it or not. So, in addition to physical therapy, there are additional treatment options. For example, we have pessaries. These are vaginal inserts that are placed for either vaginal prolapse or incontinence. They're temporary devices that are inserted either by your doctor or by yourself once you're trained on how to do it. And they can help with the vaginal sensation of prolapse or incontinence in some aspects. There are also commercial products like this one called Impressa tampons. They're no longer available at the pharmacy, but you can get them online. And they're just basically tampons that are inserted to prevent incontinence, especially if you know you're going to be engaged in a particular activity that might lead to incontinence, like maybe taking a walk in the woods or something. You can put that on and then throw it away after you're done. And then for the males, there are condom catheters, which are also available as an option for incontinence after prostate surgery. So there are two broad medications, classified medications for treatment of incontinence. And if there's anything you want to learn today, it's the two types of medications. They're anticholinergics. Those were the original class of medications used to treat this condition. Now, they've received blowback lately because data has shown that using these medications in the elderly population can lead to early onset dementia. So if you're above 65 and your doctor wants to prescribe these medications to you, just be careful. There are certain medications that are lower risk than others, but as a broad class, they do lead to memory issues. So that led to a new class of medications called beta agonists, which help with bladder relaxation so you can make it to the restroom. The two medications on that list are Myrbetriq and Jeptesa. The drawback is that they're very expensive, obviously. They're brand name medications, there are no generic options. But those companies are doing a better job of trying to get them covered by most insurances. And for patients, if you're prescribed a medication and it's too expensive, don't give up hope. There's a website out there called costplusdrugs.com. It's owned by Mark Cuban, the billionaire, and he's made a lot of these generic drugs super cheap without insurance coverage. So if the medication is cost prohibitive from your pharmacy plan, you can go to that website and get a cheaper generic version. So how do we treat surgically? How do we treat this condition? So I'll go over stress incontinence, which is the most common. The classic method of treating this condition is a synthetic sling. The synthetic sling was mentioned or first described in 1995 by a French gynecologist, and it composes of mesh fibers which are placed under the urethra, which is where you pee from, the tube, the pee tube. It's a minimally invasive procedure that's done vaginally. It takes about 15 to 30 minutes to do, outpatient procedure. There have been more than 3 million of these operations worldwide and counting. The basic job of the mesh is to recreate the sling, the support that you've lost over time with aging and multiple pregnancies and multiple deliveries and things like that. Now, the mesh has received a bad rap, but it is made of the same material, but it's not the mesh that you've probably heard of that have caused a lot of lawsuits and things like that. This is FDA approved, it's still on the market. The FDA banned most of those meshes that caused problems because they were used to fix vaginal prolapse. And the reason those problems happened was because very many people who were not well trained started putting in the meshes in a lot of women, and that caused a lot of trouble. So right now, if you want to consider this, you should do it only through a urologist or a urogynecologist that's subspecialty trained, or else you might be in trouble later on. There are alternatives to mesh. If mesh is an absolute no-no for you, you don't have to have the mesh. There's a vaginal sling that can be made from your own tissue, be it harvest tissue from your abdomen or from your leg, and use that to create a sling which can be used to support the urethra and prevent incontinence. This operation is a little bit more involved, and that's why the mesh took over. This was the original operation before the mesh. But this is a lot more painful because you have multiple incisions, takes a little longer, and you may have to have a catheter for several days to weeks. But it's still a tried and true operation to help women with incontinence, especially stress incontinence. If you don't have enough good tissue, we can use cadaveric tissue, which is from cadaver donors, or we can use xenograft or something from other animals that have been sterilized. But the best way is to go with your own tissue. Lately, urethral bulking is the injection procedure Dr. Mans mentioned earlier. This is actually a decent option for women with stress incontinence because it can be office-based or minimal sedation. Used with minimal sedation, you don't have to be put to sleep. If you were to imagine someone getting a collagen injection or lip filler, this is similar to that. We inject into the bladder, see where this area is. This is the urethra, and we inject into the wall of the urethra this gelatinous substance that stays there, and that prevents passive loss of urine with stress incontinence. Now, it's not like the gold standard, which is a sling, but it'll do a good enough job in a lot of cases. The success rate quoted here is 30 to 60%, but I found it to be a lot higher. Maybe about 70 to 80% of women get 1 or 2 injections and they're set for several years. And the durability depends on the type of substance that is used. I currently use the one on the line here called Ultimate, which was used in Europe for several years before we started using it in the US about 4 or 5 years ago, and have had pretty good success with that. Dr. Mans also mentioned the nerve stimulator. The official name is called the sacral neuromodulator or sacral nerve stimulator. I call it the bladder pacemaker. It's been around since 1997, believe it or not, but a lot of people don't know much about it. It's a pretty good treatment for overactive bladder that have not responded to medications or conservative treatments. It involves me putting in a stimulator lead or wire into your tailbone area or the sacral nerves, and use a small amount of electricity to change the behavior of the nerve to the bladder. And this is what it looks like when it's finally placed after a trial period of about a week or so. This is what a battery looks like compared to a quarter. And you can see the size of the battery is not that big. It's implanted under the skin, and it powers the device for up to 10 or 15 years, depending on how it's used. It's a pretty good operation. In terms of drawbacks, you do have to have an outpatient procedure under sedation. There's about a 1% risk of this device getting infected. If it does get infected, I have to take out everything, unfortunately, and try again when you're much better. Otherwise, I've had pretty good luck with this as well. If you don't want to have any surgery, there's a modified version of the stimulator called PTNS. This is a peripheral nerve stimulator. So this was approved in 2020. Basically, the leg nerve, called the tibial nerve, also has connections to your bladder nerves in the sacrum. So we stimulate the leg nerve in the office for about 20 minutes. This is a weekly session that you have to undergo for about 12 weeks. So it's a lot of time demand for some patients who can't come to the office every week. But for those who are retired and, if you can read a good book for 30 minutes every week in my office, So that's an option if you don't want to have surgery. And right now, the FDA has tested a number of implantable versions of this device where we can put it in your ankle and just leave it alone, and you don't have to come to the office every week. So that's currently in development. One thing that we probably haven't mentioned yet is the use of Botox. Botox has been revolutionary for women with overactive bladder. It's a toxin, and it's extracted from the bacteria. So this toxin is, cleaned up, sterilized, and then made into a medicine. Right now, you can probably associate Botox with the cosmetic industry, used to correct frown lines and things like that. Also, the urologists use it for spasms and headaches and migraines. So it has a universal use. It's like a wonder drug right now. So in the urology world, we use it for overactive bladder. It involves using a scope, which we insert into the bladder, and yes, you're awake, but at the same time, your bladder is numbed up with lidocaine for about 20 minutes before this procedure is started, and you feel nothing less than just a slight pinch inside the bladder. So the Botox is injected and distributed throughout the bladder in the office. The total amount of time this takes in my office is about 30 minutes. And most of the time, 30 minutes is 20 minutes waiting for the lidocaine to sit in. The risk I've included there include a UTI. Anything you do in the bladder might increase your risk of a UTI. Blood in urine for several days, especially if you're blood thinners. And difficulty urinating. In rare cases, the Botox might work a little bit too well and make it hard for you to urinate. And that might require a temporary catheter, but that happens in less than 3 or 4% of patients that do get the Botox. So I think I have a few minutes to just discuss pelvic organ prolapse, which is another subset of pelvic floor disorders for women. It's the loss of support for the uterus, the bladder, or colon, or the rectum, which leads to prolapse or herniation of one of these organs into the vagina. There are a lot of risk factors, mostly family history, race and ethnicity, age. There are certain collagen disorders like Marfan syndrome that might predispose you to increased risk. If you've had a hysterectomy, you're probably at risk because your support structures have been violated. A high BMI or increased weight, smoking, chronic cough, and there's certain occupations. For example, I had a UPS worker who had prolapse after lifting a lot of heavy boxes over her lifetime. And then socioeconomic status could be a risk factor as well. So the common symptoms are bulging sensation in the vagina. Sometimes the patient may see something after getting out of the shower or drying up, and a lot of times they're shocked. You may have some bleeding. Incontinence could be one of the symptoms, as well as overactive bladder complaints, having the need to go to the bathroom frequently and urgently. Some women also experience incomplete bladder emptying, where the prolapse is very advanced and the bladder has fallen out significantly, and they have trouble emptying their bladder, or they strain to void. Sometimes they have to manually put the bladder back in the vagina in order to pee. That's definitely a sign. Constipation, fecal incontinence, incomplete defecation, or not being able to properly have a bowel movement. There could be sexual symptoms as well, such as painful intercourse or incontinence during intercourse. So those are all symptoms. This diagram kind of shows what the normal looks like. So the bladder will be here. This is the vaginal canal, and in prolapse section, the bladder just falls through the vaginal canal and creates a bulge. And same thing on the rectal side. This can be managed same way, non-surgically, with pelvic floor exercises. Pessaries are there to reduce the prolapse, to reduce those symptoms, and they've worked well for a lot of women, so you don't have to have surgery. The pelvic floor exercises do not reverse the prolapse, but it does improve your symptoms. So you will have easier time urinating, emptying the bladder, or having a bowel movement. Surgery is there's a lot of surgical options, which is too broad for me to cover here. So the need for surgery is a patient decision. It's how bad you feel about this, how bothered you are. If it's there, but you never noticed it, and your doctor notices and say, hey, your bladder has fallen. If you never noticed it, you don't need to have surgery. It's plain and simple. It's only for symptomatic patients. And I listed the symptoms previously. So the type of surgery depends on your preference, like I said, and other factors. You have to be educated because there's more than one type of surgery for this problem, and it depends on a number of things. Are you sexually active or not? Do you have more than one segment of your pelvic floor that has prolapse? These are all questions that need to be answered before we decide what surgery is best. So in conclusion, I just want to come across, we learned that incontinence and pelvic organ prolapse symptoms are common, and it incurs a high cost to you as a patient as well as to the health system. The incidence and the prevalence will increase with age, the number of pregnancy or childbirth, as well as obesity. Physiotherapy should be offered as a first line if you do encounter these problems, especially with the help of a physical therapist. Things can improve. The gold standard for stress incontinence is synthetic slings, which is the most common surgery, but there are other alternatives if you do not want the sling. Surgery is not always needed for mild or asymptomatic prolapse. That's another message today. If you are symptomatic, then yes. If you're not, you can leave it alone and watch it. And there are other less invasive options that will lead to moderate improvement of SUI and the quality of life. So I hope I covered everything I was supposed to, and I thank you for your time and for listening to me today.
Thank you both. So now this time is for question and answers. So if anyone has any questions, you can either go to that mic or I can bring the mic to you if you have any questions for either one of the doctors.
I don't understand how social economic status is a factor.
So it's more so just not having the access to care, and those early signs are often ignored a lot of time. Yeah, just the access.
One of the things I found when I was in training, basically the expertise of the obstetrician has something to do with how well a woman does after having babies. And we did, as he was saying, more and more time a woman is pregnant, there's increased weakness of the floor, but at the same time, education of what they should be doing between pregnancies is very important. So that's why education is important. And I always stress, treat the whole patient rather than just treat the patient for one symptom.
And that's correct. And this, one thing I'll add on to that is a lot of gynecologists are now recognizing that the risk factors and encouraging women to see a physical therapist after vaginal delivery in order to do those exercises, so at least they're introduced to it at one point in their lifetime. So if they need to remember to do those exercises, they can in the future. But it's important to at least educate every woman who's pregnant after delivery, please start doing pelvic floor exercises as a preventive measure.
So my apologies, I got here just a little bit late, but my question was about overflow incontinence. So as a male, any suggestions is possible prostate any kind of involvement, or what could be some possible non-surgical treatments?
So overflow incontinence is brought on by the bladder's inability to empty, and that could happen for two reasons. One, the bladder is too weak to exert enough pressure to push out the urine, or two, the bladder is encountering resistance and it cannot empty. And in men, that resistance is likely due to a prostate, okay? And so if that's the issue, unfortunately, there are very few non-surgical treatments for enlarged prostate. You can try medications like Flomax or Tamsulosin, but that's only temporary. In most cases, the man will need surgery or some sort of procedure to open up that outlet so that the bladder can empty better. Because if you don't address it early, eventually the bladder will decompensate and not be able to do its normal function over time.
I think for men who have prostate cancer, who have surgery, many of them need to have the pelvic exercises also. And I think sometimes we kind of forget that, because I remember for me, 26 years ago, I had to begin to do that. And there's other men who had great problems with incontinence after surgery. If you're able to do those exercises, many times you can prevent a lot of problems down the road. But you also have to do another thing that I find many people get physical therapy. They get the physical therapy, they get a program at home, then they stop doing it. Then what happens? The muscles become weak, and you're back to square one again. So many times, when you get a therapist, you have to get a home program, and you have to do the whole program continuously.
My question concerns Americans versus other countries. Needless to say, we just need to be concerned about the U.S. of A., so to speak. But you gave these, one of you all gave the occurrence. So how does the occurrence for Americans compare to other countries? And I know, we're more developed than others, but still, sometimes we see in various things, other countries are far better off than we are, particularly with weight. So with this urinary incontinence, how does America compare with other countries? That's my first question.
So it's hard to tell because each country presents this data differently. We know it's very prevalent in the U.S. because, we partially know because we use Medicare data, so we have the information from Medicare data. In other countries, like in Europe, they have national health insurance, and so they have more complete data than we do. So even though we have a high prevalence based on European data, from what I can understand, it's just equally as high. Okay, but I think we have an incomplete picture because we're only using Medicare data to get that information.
Okay. And then when you were talking about non-surgical treatment, one thing you mentioned was urethral inserts, and you said essentially that's a condom. Tampon.
Yes. Yeah.
Just a regular tampon.
No. This is not a regular tampon.
Okay,
Yeah.
but I'm asking that
Yeah.
because, I knew the answer.
Right.
But I'm asking that because everybody does not understand that some of it's a 747, so that's
Right.
why I'm asking.
No, it's not a regular tampon. It's a pharmaceutical product, but like I said, it's only available online.
After a hysterectomy, what's the best exercises or to do? Because a lot of people that get hysterectomies, doctors don't tell them that they're going to have problems.
Mm-hmm.
And so you don't start with exercises, and then you realize, man, there's a difference.
Mm-hmm. So it's the squeeze and release technique. So what I tell women is, if, for example, if you're in a public restroom urinating and someone walked in and you wanted to stop your stream, the same muscles you need to stop your stream, you just squeeze them and release continuously, and that's the exercise. Now, hysterectomy is a special case because it's a surgical violation of your support structures, and depending on how it's done, if it's not done properly, your entire support structure may fall and just be, compromised. And so it depends on the reason you're having a hysterectomy done. A lot of times it's for cancer, and we understand that's necessary, but a lot of times it's done for either abnormal bleeding or maybe prolapse. If your hysterectomy is done for a prolapse, they have to address the reason your uterus prolapsed in the first place, because the rest of the organs will prolapse again once the uterus is gone. So it's a bystander. The uterus is a bystander when it comes to prolapse. It's prolapsing because their structures are weak, and if they just take out the uterus and think that that's going to fix the problem, it will not.
You have a better outcome with hysterectomies with robotics versus laparoscopic?
No, they're equal.
They're equal?
Yeah.
So I have another question, just out of curiosity. I know we speak a lot about social economics and stuff,
Yeah.
but in something as simple as like overflow incontinence,
Mhm.
men specifically,
Yeah.
is it more social economics or just unwillingness to open up that conversation?
No, I think it's the unwillingness. So, for example, a lot of men with overflow may not realize they're overflowing, and at that point you have to make sure they're not diabetic, for one, because that will place them at risk for having a weak bladder or underactive bladder. Number two, they have a history of weak stream or difficulty urinating, then they may have a large prostate that needs to be addressed. But these things are not, kitchen table discussions to have. And so if you don't have an honest discussion with your doctor, and I tell a lot of women that, mention it to your primary care, say, hey, I've been leaking lately, what can I do about this? Because that puts you in a pipeline to see somebody. Even if it's not serious right now, it might get serious a year or two from now. And so if they refer you to somebody, you're not going to have to wait too long.
Sorry about that. So, again, it goes back to the man aspect.
Mm-hmm.
Is it more like we've been dealing with the prostate, the uncomfortability of what's about to happen for a male to even want to go down the avenue, or to just you just want to just say, I'm getting older, or what do you mostly find that men are mostly afraid of?
I don't know, men just have a phobia of doctors, for one. They only go when they're really sick. They think, I don't know the reason behind that. And I think it just needs to be a cultural shift where we encourage men from a young age to see a doctor regularly, because you can catch things that you probably didn't notice before. So it's more of a cultural thing, the macho thing, just not having to see anybody because I feel fine,
There was a program several years ago on Tom Joyner. Wives take their husbands to the doctor. And they found many of men got saved by that way. And not just for prostates, but also for heart disease, for diabetes, avoiding the complications. So what happened to us is that we have to be our brother's keepers. And we've kind of forgotten that. And that's the part that comes from respect, taking care of people, being sincere. That's one of the things that we have to become cognitive of, is trying to help other people, advise other people to make the right decision. And you don't have to bug them, but you can just try to be sincere to try to get them to do the right thing.
My question is, how do exercise make this problem worse? For instance, if you're climbing up and down stairs in your house, up and down, up and down, up and down. If you're working out in your yard, you don't like to go to the garden, or you have to do a little digging, how
I wouldn't say it's affecting the incontinence, more so like exposing it, okay? So if you have stress incontinence and you're an avid jogger or you exercise a lot, those strenuous exercises increase pressure on your abdomen, and then you have no way of stopping, because the natural instinct of the body is to close things up when you're doing those exercises. But if you have stress incontinence, it's wide open. And so no matter what you do, when you bear down, when you pick something heavy, or you exercise, the urine just drips. And it's not that you're making it worse, you're just exposing it.
So your job would be to do the exercises that would strengthen that.
Yes.
So when you see a problem, you have, the most important thing is to figure out why. Then you work on the why, then you increase the effect. But many people will have this, but what they do, they don't do the pelvic exercises. They don't find a physical therapist. They don't eat right. They continue to eat lots of sweets. They continue to drink lots of caffeine. They can continue to do all the things that can make the problem worse. So you have to begin to go at the foundation. That's why I gave that handout, so you can have in your hands, look at things that can make things worse. And in America, what do we have? We have the standard American diet. We stand for SAD, or sick diet. We should be developing more a whole food or Mediterranean type diet with less processed foods, less sugars, less refined sugars, more water, okay, etc.
So certainly doing a conversation like this tonight is eye-openers, but moving forward as you go out into the world and your careers, as talking to friends, family, whoever, how do you begin the conversations in a respectful manner, not to be prying so personal? It's one thing when you come to a doctor's office, again, you want to be personal, but it's not until I see the doctor when I say, hey, I think this was happening. But honestly, with my medical background, honestly, for myself, it's kind of shameful. So it's not until you go into stuff at Google online forums and you start to see other men around your age range and so forth dealing with this. And lastly, I know it's a couple of questions, but when you're on testosterone replacement therapy, does high levels of testosterone possibly cause or affect those as well?
Yes, I'll take the testosterone question. Yeah, testosterone, so the prostate feeds on testosterone. So if you're on testosterone therapy, you have to make sure your PSA is being monitored. The prostate can get even more enlarged while on testosterone therapy, so that can worsen your urinary symptoms if you have that to begin with. It's in some studies it's shown increased overactive bladder as well. As far as the discussion, I don't have much experience bringing this topic up with my friends or anything, and I'm guilty of that. You know, even as a urologist, it feels natural to me talking to my colleagues, but you know, personal friends, I really don't want to pry. But if I do notice that someone is going to the bathroom every 30 minutes, that's an easy discussion. Hey, are you okay? Why are you going every 30 minutes? We get this, you know, there's solutions for that if that's a problem, because if they confess to having this problem, especially all day, all night, then that's an easy discussion.
Thank you both for this presentation. We appreciate it, and the topics have been discussed. I have a question. If a patient presents to their primary care physician and they're having some difficulty being heard and kind of getting the referral that they need, and I know most of the time for subspecialists, the referrals needed. Any suggestions with regards to that? Are they able to request you personally?
Oh yeah, they can request a subspecialty referral from the primary care. Fortunately, in our practice, we do accept direct patients. Like, you know, we don't need referrals to see us. So if you don't have a referral, you can make an appointment directly by calling.
One of the problems is that we have with respect to doctor's offices, we have gatekeepers. And these gatekeepers many times is unforgiving. But as I said, I think a couple of other meetings, that if you have a relationship with those doctors, call them, state your case, no matter how busy they are, you get in. So one of the things that we have to stress, one thing with respect to this whole series, is that we have to realize that relationships and respect is very important. Because many of the patients have in life-changing situations that they can't wait 2 weeks or 3 weeks or a month to get taken care of. So you have to be receptive to say, I need to get on the phone and call that doctor. But if you call their staff, they'll say, sorry, we can't see you for January. The doctor, they do not even know that, because that's not our what we call it, our MO.
So yeah, he does bring up a good point there. If there's a reason you want to see the doctor urgently, you should make the case and ask the person or gatekeeper, whoever is handling that call, to speak to the doctor directly and to follow up with you. That's the most important thing. Say, tell the doctor, this is my problem, I'd like to see them early. Can you follow up with me after you've talked to them? If you give the message in that way, and not threatening way, don't be mean or anything. If you're nice to them and they see that you really want to see the doctor, they'll relay that message to me or whoever is in charge. And I'll look at your history and say, okay, yeah, this seems more important, that I should see this person on this day. Or if I feel like my nurse practitioner can handle it, I will say, she can see that person sooner than I can. So it's just relaying the importance of your condition and then asking for follow-up after you've done that.
Any more questions?
Thank you.
All right, thank you both very much.
It's Henry Okafor. So I tell people, it's like you're calling a cab. Yeah.